Can I just say I thought that was a really good talk. It's something that I don't really think about because I do a lot of pancreatic cancer work, gallbladder cancer work, cholangiocarcinoma work. And if I very occasionally find metastases, that's it, we stop, biopsy, prove it. But I must admit, it's not, with imaging being so good, I don't often come across peritoneal mets for just pure liver resections. And when I do, I wouldn't proceed because I'd be worried about what my colleagues would say. Why on earth are you doing that? But you've presented a lot of information that I just didn't know. So I will take this opportunity to go and discuss that with my colleagues because it makes complete sense. Anyway, sorry to interrupt on that bit. So I've been asked to talk about it. I mean, what a great management of colorectal liver metastases. Where do you start? Because it's like, often get asked, say, the role of neoadjuvant chemotherapy, the role of, disappearing metastases after, all can take a long time. This is a really big subject. We've got half an hour. Most of you are colorectal surgeons, so I've tried just to keep this pretty basic. And to me, I reckon they're about, not because no disrespect, all right, but to me, there are two slides in there that are really important for your work. I'm not going to tell you what they are. I may do when we get to them, but two things to take away from this. Where's our buttons and things? Just background. I'm only going to give you 4 bits of background because that sort of just covers the whole thing and what we're trying to achieve. 50% of patients diagnosed with colorectal cancer eventually develop colorectal metastases, whether that's synchronous or metachronous, and that's a lot. So that's going to happen to a lot of your patients. Of those that do, it always surprises me, it's only a minority of them that we actually get to operate on. So to me, the figure is about, I'll put 10 to 25, I'd say it's about 20-25%. So the rest of them don't really even get considered for it. The other thing to point out, though, that this resecting livers has not been going on that long. Before, I remember going to MDTs as a trainee, you'd see someone with a solitary liver met and they would in unison say, oh, they're doomed. And they didn't even think of talking about surgery or anything like that. So nowadays, when I first started, I was quoting a 33% 5-year survival. Now it's up to 50%, so that's really good. And I said earlier, I do pancreatic cancer, gallbladder cancer. The prognosis there is appalling. Colorectal is good. I mean, that's really good odds. And the best thing about that is if you develop a liver met, take it away, you have a 50% 5-year survival. If you develop another one, you go back, take it away, you go back to square one, you've got another 5-year survival. So things, I'll cover that in the talk. We've changed things to make sure we can go back to help get that 50% 5-year each time. So in fact, that covers it. So I don't think there's any doubt. If you've got a liver metastasis, the best way, curative intent, is to take it out, and everything is directed to be able to do that. And I'll explain that all in this talk. What am I going to do? I just summarised that. Again, looks a bit busy, but I was just trying to put this in a logical order. Briefly, going to tell you about. For me, it's understanding the anatomy. And that's what determines what we can resect. So what I'm going to try and get across is that anyone that sees a liver met should ask someone that looks at them all the time. You can't be expected to know that because it's not as you seem. With part of that, I'll also just explain the technical criteria, and it's really simple. It's just 3 things. As we go back more and more often, people get recurrences. You mentioned parenchymal sparing resections for their liver resections when they combine them. That's exactly what we do. Take as little liver as possible. And there are lots of ways of doing that. The role of neoadjuvant and perioperative systemic chemotherapy, well, that's a massive subject. It's really confusing. I've boiled it down to just 2 studies. And there's no hard evidence that it actually is any good. I increases overall survival, perhaps progression-free survival. I'll touch on that briefly. But there's very logical reasons for giving that chemotherapy, which I'll summarise for you. And then to me, the most important thing is just realise multidisciplinary teams. Because I've just learnt something here. I just didn't know. I come to the St. Mark's MDT, and I know people are interested in starting up this sort of service here, but it's something I'm just not aware of, and it will maybe change my practice, so that's good. So this is just briefly. I put this here because on our ward, which is a liver HPB ward, they had, I think it was probably even this diagram, they had this up and they had this label, that's sort of falciform ligament teres. They had that labeled as the left lobe of the liver. Lots of people think that is the left lobe of the liver. I mean, lots of people that present saying they've done a left hepatectomy, it's not, it's just the lateral, left lateral 2 and 3. The middle of the liver comes down here, which I'll show you. Morphological, everything is determined on the blood going in and the blood going out. All right, so I'm sure you'll remember portal vein, 75% of blood flow to the liver, 25 is hepatic artery. You've got 3 veins going out, right, middle, left, and that is exactly what determines what goes on. The biliary tree just goes the other way. That's all you need to know. And I've said this already. This is what determines everything. It's really where the veins are. So middle hepatic vein goes from the left side of the IVC down to the gallbladder fossa. That's your right and left. And when you do lap choles, always remember sometimes there's a big vein from the middle hepatic artery there. I've seen that bleed quite a bit, so don't be too enthusiastic with your... and then it gets all a bit more complicated. Here you don't need to know all this, but this is exactly how we work things out. We say middle hepatic vein is right and left, and then on the left, well, segment 1 is actually behind everything. It's between the portal vein, segment 1, and IVC. And segment 1 actually goes all the way up to the hepatic veins. It's not just your little caudate nubbly bit that sticks out. That is only the nubbins. The whole thing goes all the way up. So when someone talks about segment 1, that's where it is. The left lateral, which is determined by the left hepatic vein, 2 and 3. 4 is still on the left. Then we get to the middle hepatic vein. And then essentially there are 4 segments there, 5, 6, 7, 8, divided by the right hepatic vein. Just have to know a rough idea. I always put this diagram here because that is this one's in real life. This one is a liver that's taken out and put on the table. The posterior segments are right round the back. But if you plop something on the table, they look like they're really accessible. In real life, they're right round the back. And you'll go to meetings and say, oh, that'll be easy, down there. No, it won't be easy. It's very difficult to get to. Okay, so old-fashioned surgery, where you're not doing parenchymal sparing, the big problem with liver surgery is it bleeds like bilio when you start doing it. So even if, say, you had a small metastasis here, the safest way to do it is actually to do a right hepatectomy, because you take the right portal vein, you take the hepatic artery, it still bleeds lots because there's lots of flow coming across from the other side. So that's how you determine the anatomical resections, is knowing the anatomy. And there's right hepatectomy left, extended left, right. You can get very adventurous, then start right posterior, etc. That's sort of good old-fashioned surgery. And I'll come back to that in a moment. So this actually is one of the important slides. Previously, you'll find lots of papers saying, what are the contraindications? If they've got bilobar liver mets, you can't operate. That's not true. If you've got more than 4 lesions, can't operate. And plenty of papers saying why they don't do so well, etc. That doesn't count. You can have as many as you want. Large tumours greater than 5, 10, doesn't matter. Extrahepatic disease. So we have good talk here, and certainly we used to worry about people with high lymph nodes. There's plenty of hard data there showing that they still do a lot better even if you do a high lymphadenectomy. I think that the reluctance before has been that liver surgery hasn't historically been that safe. People bled to death, and the morbidity was high, the mortality was high. I'll cover that a bit later, but now it's really safe. So everyone starts doing more and more. So to me, there are only 3 contraindications apart from peritoneal metastases. One, you've got to have you can't take away more than 70% in a healthy liver. So people say you can leave 25%. I'd go about 33% is safe. And that's assuming it's a normal liver, not someone that's cirrhotic, and not someone that's had lots of chemotherapy, because their livers take a bashing from the whole thing. So you're going to have 30% left. You've got to have at least 2 segments, which covers that, and you can start doing all sorts of clever things to try and get that. And if you think about it, you have to have 1 portal vein free to bring the blood in, and 1 hepatic vein to go out. So if there are 2 involved, and you can even get adventurous taking hepatic arteries and things, that's being slightly dangerous. But if you think about it, if someone has a bleed, interventional radiologists don't hesitate to embolize an hepatic artery. So to me, if you've got 30% of liver, you've got one portal vein, and you've got one hepatic vein, then in theory, you can do an operation. So that's the importance of people looking at scans and working out what can be done. How do you determine that? I've just put these here because it's got a nice little video at the end. So you can see this is a tumour here. That's the left portal vein. You can see that the right portal vein is obviously involved and probably the left. You've got an MRCP. This patient actually presented with obstructive jaundice. You can see that's the right hepatic duct. That's definitely gone. The left is probably involved as well. And then if you're lucky, not many people get to be lucky this, you can do all sorts of clever 3D things and work out what's going to go on, and I'll stop it in a second. If you can read CT scans, you don't need this because it actually comes from CT scans. Ah, blast. If I just go back, I was hoping to stop that in the right place. I'll probably stop it there. It doesn't work. Anyway, it shows very nicely that it's going around the vein. And then you can have other programs that say what you need to take away. This isn't actually necessary if you can read CT scans though, because all the data comes from a CT scan. So you need one vein, you need one portal vein, you need at least 30%, but it's very difficult to predict whether that 30% will work properly. So to me, the biggest risk of doing liver surgery, you look at it, if they're cirrhotic, you need at least 40%, but even if you do small resections, they go into crushing liver failure. It's very difficult to predict. So sometimes a patient will come along and need a right hepatectomy, but their left lobe is definitely too small to do it. We have ways of making the left lobe bigger. I'm sure you've come across portal vein embolizations. So that's just essentially embolizing a portal vein. Just use this as an example. This is a patient probably with a cholangiocarcinoma. That's his segment 4, which is part of the left lobe. And you need to take everything and just leave actually segments 2 and 3. So it goes back to two segments. Now, obviously, you calculate it all. You've only got 14% of liver. That's not going to do. You can't do anything there. If you embolize the right side, the left side should hypertrophy. The first thing you'll notice here that this is not a very safe way of doing this, because you want this to be here still at the end. So if anyone rogers this or cocks it up, that's it, game over, you can't do anything. So most people would actually come from the right side because that's going to go anyway, but it's a lot more difficult. And essentially, they get access to the portal vein, and I always ask them what do you put in there. They actually have a shelf, and they just put in glue, coils, whatever it takes. There's no sort of protocol. They say, oh, give us those big ones there. This is that. So they just whack a load of stuff in. And you can see that nicely stops it. It's all very clever. And then later, in theory, you only need about two weeks before hypertrophy is enough. To me, if you're doing a big operation, I want it to be 4 weeks plus, just to make sure. But here we've got some measurements. We've got a 21% increase, and we had 14% to start with. Then it's safe to carry on. All right, so that's what we do. If something's not big enough on the other side. It brings us to another. This is just a couple of pictures. So this is the gallbladder. So that's the right lobe of the liver. And you can see that's atrophied nicely. This is absolutely enormous now. There's no problem there at all. And this is just a picture. That's the left lateral, segments 2 and 3. That's enormous. So that's plenty there. I could have had that. So if you've got that in store, you can actually start doing clever things. You've got bilobal liver mets, which I said a bit earlier. So used to be a complete, absolute contraindication to resecting. You can then start doing 2-stage liver resections. This is the way it usually works out. You've got someone here with metastases right side and left side. You go and sort out the metastases on the left side because that's the bit that's too small for you to do your operation straight away. You can do that open, you can do that laparoscopically, whatever. So you can resect those if possible. One thing I haven't addressed in this talk, and I'm just realizing it as I speak, is that we use radiofrequency ablation of tumours as well as a treatment mode, but also when we operate, because sometimes you just can't take everything away, and it's absolutely fine to ablate things if they're small because the results are essentially the same. So we do that if required. So when you finish sorting out the mets on the left, you can either, at the time of the operation, tie off the portal vein on the other side or put a clip on it, or previously we used to, before they were discharged, embolize their portal vein and then leave them 3 weeks plus, bring them back, By then, hopefully, a CT scan has shown that you've got nice hypertrophy of the left, and you can just go ahead and do your right hepatectomy. All right, so that's sort of increased the number of patients we can operate on by doing a number of things. People are taking it even further, because sometimes you go to do that, but you don't get enough hypertrophy, so everyone's got very excited about ALPS, and I'm going to have to read it out, associating liver partition and portal vein ligation for stage hepatectomy. So essentially what you're doing there is you're dividing the portal vein. Well, you're sorting out the left side again, you're tying off the portal vein, but on top of that, you're also dividing the liver parenchyma, because even if you take portal vein, artery, etc., you can't just cut through the liver. There's lots of blood supply coming from the other side. So even if you completely isolate that, there's a lot of blood coming the other way. So if you transect the liver without completely just leaving the artery and the hepatic vein there, you get even more hypertrophy. Now, everyone got really excited about this, and I remember people presenting and said, yes, so we did 20 and only 6 of them died and all that sort of stuff. It's just astonishing what they're presenting. And I've done quite a few now. If you do a proper transection, it really is a hard hit to a patient, because they've often had chemotherapy first, then you've operated on them, then you've tied off their portal vein, and then you're going to go back and doing a right hepatectomy. It really takes it out of them. I'll come, in fact, this might show it. Yeah, so when you've finished, you put a plastic bag around it to stop everything sticking to it. You make sure you mark your hepatic ducts and artery and your vein, so you can find it really easily. I've put this here because there is an alternative. Rather than just transecting, you can just radiofrequency ablate it, which gets rid of the blood supply. And this is someone I did, and I must admit I was kind of frightened when I saw the pictures that had gone right down there without quite realising, being a bit over-enthusiastic, but obviously it's perfect precision surgery. That was absolutely fine. You come back, that's what the liver looks like, and it's a relatively straightforward thing. You divide the artery, bile duct, and vein. We've done all the hard work beforehand. So I think there's lots to talk about that. We do it I tend to do it when required. Anyway, I won't go into all those details, but that's another option to get even more hypertrophy, to try and get more people to be able to operate on. So I think that's covered the getting enough functional liver left for you to safely do an operation. I've talked about conventional hepatectomies and with segments. Here, I'd say 55 to 65% of patients that have liver mets will develop further intrahepatic liver mets within 3 years, and that's quite a lot, isn't it? So as we're expecting to go back, and I think the most I've been back is 3 times for relatively major things till you got down to 2 segments, you try and do as little as possible to get all the tumour out. Now obviously the problem with that is cutting through liver is it bleeds a lot. And if you look back, the 1980s, the mortality from liver resections was something like 10 to 20%. I'd started at the Hammersmith, one of the pioneers in liver surgery used to work there, and one of the sisters that worked with him used to say they'd all be in Wellington boots and there'd be blood all over the floor. There's just lots of blood loss. It was a lot. It's now acceptable to have a less than 5% mortality, but in reality it should be less than 1%. And it usually is everywhere. And as I said, so how do you do how do you do parenchymal preserving things? You have to find a good way of being able to transect the liver. And if you do a PubMed research over the last, up to the fact we go from 127 in the 70s to over 22,000, most of those are actually people talking about, I've got the best way of resecting the liver. This is bloodless. I do this, I do that. That only means one thing, is that no one way is the best way, because everyone would be doing that. And in the old days, I've worked with someone who just uses his fingers, and if you think about it, all you're trying to do is, if you think of a biliary tree as a tree with branches, hepatocytes and blood vessels, hepatocytes are the leaves, you're just squishing down to find where it is. I wouldn't recommend that at all. But that's what they used to do in the 70s. And he worked for the guy who used to do that. He came to theatre me once. I nearly had a heart attack. He wasn't a liver surgeon. He said, we'll be all right, we'll be fine here. Anyway, so lots of different ways. This actually looks old-fashioned. It's just fracturing with forceps, clamp. And I actually use that quite a bit when we're getting near the end of operation if it starts bleeding, because it just moves things along. But again, it's the same thing. You're just delicately knocking away, diatherming the small vessels, all the big vessels, you're tying and so forth. I think there's someone at the Royal Free who still does it this way. And certainly I've been abroad, lots of people do that. It's a good way. There was a phase of doing total vascular exclusion, where you're clamping the inflow, doing a Pringles manoeuvre, nothing's going in, clamping IVC below the liver and above, nothing's going in, get your knife out, chop, then start stitching. Now obviously the patient doesn't respond to that very well, suddenly having no output and all that stuff. So that soon went out, they all ended up on ITU. Then after that, so those are the basic ways of doing it. Kuzar is the way most people do it. Won't go into details, but that's what most people use. It vibrates, gets hepatocytes, explodes, you can see the vessels you need and take it. It's very long, laborious, it just carries on bleeding a bit by bit, nothing major. But that is the best way to be able to see big structures. Then people can use harmonic scalpels, they can use, what's the other, ligature, that's radiofrequency energy. Radiofrequency energy is something that's used quite a bit, so there are lots of things to do that. I tend to use it with this thing here, which is actually a monopolar RFA. It's designed for tumours that you can't resect, but it works very well with just normal parenchyma. It completely coagulates vessels and biliary tree, and you can use it like a Kuzar. But it does take a long time. All right. So what's the advantage of that? If you know your anatomy and you've got a tool that you can use well. Now everyone is trained with different people, so the secret is working out what works well for you. That's why everyone uses different things. All right. And so if what I use, I'm having a problem with it, I use someone else's, I get into problems because I get lots of bleeding because I just don't remember how I used it the last time I used it. So whatever works well for you. So for instance, this is a patient, July 2015, 3 METs, one in segment 8 at the top, one on the left, and a big one on the right. You can't, we just do it like this. It has some chemotherapy, it's pretty much the same. Those are the 3 things. The easy thing would be just take the right liver and then take that, but there wouldn't be enough left. But if you're careful, you can start doing sort of bespoke surgery. So you can just wedge that. You can do a sort of inferior right hepatectomy, etc. And you can just do lots of things, but you need to know your anatomy and work out what's going on. So lots of times, I think it's getting less and less often that I have to do embolizations, etc. like that preoperatively. So I'm not going to dwell on chemotherapy because this is a whole hour's talk anyway. I will point out some very simple things to go from. This is a slide for patients having palliative chemotherapy, all right? And if you look, I'll explain it. Not so long ago, it was just best supportive care and you were dead within 6 months. And then not so long ago, someone had the idea of giving 5 off FU and you're getting up to a year. And then since then, you can read, it's very confusing reading the literature because there's so many different variations, etc. But you're getting up to 2 years, and it's even more than that now. All right. So with that in mind, people are getting such good results from palliative chemotherapy where there's not going to be a chance at all of operating. It seems reasonable to use that in the setting of resecting metastases. Now, I put this here because it's important. To justify the use, you should have significant improvement of disease-free and long-term survival. There isn't that with neoadjuvant chemotherapy. But people still use it. And it's sort of now divided into sort of 2 camps. Those that have resectable disease, pretty much all of them will have chemotherapy before you do anything. And I'll explain that a bit more. Even though it's resectable, you still do that. And I've got a slide explaining why. But also there's a load that are borderline. They're not completely inoperable, not straightforward inoperable, they're borderline. So you'd be giving them chemotherapy in the hope of reducing their tumour burden so you can operate at a later date. Trouble is, reported response rate of 50%, I think that's that's optimistic. And for various reasons, of those 50% that do respond, you still only get about 20% of those that you end up operating on for various problems, toxicity from the chemotherapy, etc. This is the slide. So I just put this. So this is someone looking, this is in the Lancet, 2008. They're looking at giving FOLFOX4 and surgery versus just surgery alone for resectable liver metastases. Okay, and they got all excited, and they're saying there's a progression, increase of progression-free survival at 3 years, and they're quoting, what have we got here? 21 versus 35 with chemo, an increase in the median progression-free survival, so from 11 to about 18, 19 months. So that is the only evidence why people give chemotherapy. They looked at the long-term results, and I think just come down here, they found no difference in overall survival with the perioperative chemotherapy and those that just had surgery alone. So the reason everyone has this is no strong evidence. They've tried adding, I think there's one nice paper with adding cetuximab. The patients that had the cetuximab and the FOLFOX4 did worse than those that had nothing. All right, their outcome was worse. So I'll just go back to this. Because they've observed that progression-free survival before, that is why it's reasonable to give it. And that's really not what I call hard evidence. But to me, I'm not happy. Exceptional circumstances, you operate on someone that hasn't had chemo. We don't need to go to that. But one, if you've got big tumours, you need big resections to get them out. If they respond, that's great. You're going to have a lesser liver resection, so that works out better for them. And if you think about it, if you've got most people have micro metastases you just don't see, so that's good for that. That makes common sense. That's logical. If you operate and then have a complication, which you do occasionally get in livers, and those complications go on for months, that patient has missed the boat. They become immunocompromised. If they've got micrometastases, then they all go ping, ping, ping. So that's another good way of doing it. And not so long ago, when they started doing liver surgery, when you saw someone with a liver met, you didn't actually give them any chemotherapy because there was no known chemotherapy to give. You just waited 3 months, then did another scan, and then it looked about the same, then you'd operate. Or you'd have lots of new metastases. That's the way they were deciding which ones they'd operate on. So now it seems completely reasonable to give the chemotherapy because you're all going to benefit from that. So that's why we give the chemotherapy. The disadvantages, one, it might progress, but then that's good because then otherwise you're doing a wasted hepatectomy and they get metastases everywhere. To me now, the biggest problem is getting metastases that radiologically disappear. Right? You've got to be really careful. You have to give, let's say, 4 cycles, then scan again, and then make sure you can still see the things and you work out which way it's going. Sometimes oncologists get a bit enthusiastic, and before you know it, you've had 12 cycles and you can't see anything at all. And if you can't see it, you can't take it out unless you know there are 5 in the right lobe, and you just do a blind resection, which you're allowed doing. But so to me, that's the big thing: is timing it and keeping a close eye. It's difficult coordinating that between hospitals. Another potential disadvantage is lots of chemotherapy gives lots of chemotoxicity, CASH, chemotherapy-associated steatohepatitis with irinotecan, just steatosis with 5-FU and other things with oxaliplatin we see quite a lot. So when people stop their chemo, they've been imaged, we wait at least a month before we start resecting. And the ones that had lots of chemotherapy, even though you haven't done such a big resection, some of them go into quite profound liver failure. So you have to be careful. We don't need more detail on that. So this is actually the other important slide. It is all multidisciplinary. All right, you need to talk to your colorectal surgeons, your oncologists, everyone needs to be communicating because it's really complex. And I think a small solitary liver met, there's no brainer. Resect it when it's the right time. If you've got metastases everywhere, then it's a no-brainer that having palliative chemotherapy. But in between that is a lot of patients, and the overlap that going this way, it's really complicated. It gets very confusing. And I came across this paper not so long ago from 2005 by Graham Poston, who's a liver surgeon in Liverpool, a very clever man. And he was trying to work out algorithms with some clever computer chap in America and trying to work out once the patient has either decided he wants treatment or the surgeon has decided that he's fit enough to offer that. And he looks at all the, I don't think, can you see those? Oh, you can see it better than I can. But if you think about it, there are a lot of permutations like resection, immediate resection, one stage, blah, 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 local ablation, chemotherapy, blah, whatever. This is the figure they came up with. This is in 2005. 2.4 million permutations of which way their treatment will go. And that needs to be even more complicated now. So that's, I'm not quite sure what they're taking there. That seems like an awful lot. But it is really, really complicated. And I go to other MDTs, not necessarily here, but they ask sensible questions here. But some other ones, they always want protocols. And I'm really wary of protocols, because you've got a protocol, you know, there's so many variations. Protocols are good for certain things, but not good for others, so I find it very difficult, because it's all different. And then I think when I first started working, I used to go to other MDTs at a different hospital, and there they didn't refer anyone to have liver resections. They'd look at something and say they're doomed. I got a letter about this patient who actually came from St Mark's in 2010, I think. And I got a letter about him the other day, so I was just looking through his old scans, and it'll literally take 2 minutes. This started off in 2010. He presented with large bowel obstruction. You can see that's where it is, dilated bowel, and he had 2 big liver mets, one on the left, one on the right. So he went on to have, that's 2010, had his colonic stent, then he had some chemotherapy, re-imaged after 3 cycles, it progressed, changed the chemotherapy, re-imaged, it had progressed. So unusually with this patient, we decided to operate on him because he was fit, and yeah, that's what was going to kill him. His liver mets were getting bigger and bigger. Had the resection of the liver in June, and then his colonic resection in August 2011. I'm sort of making a point this, bear with me. All right, and then over the years, April 2012, a lung met, which was RFA'd, another liver met in the residual liver, that was RFA'd. That's them both being ablated. Then August, another 2 in the right, both ablated. April 2013, one in the liver, the lung, ablated. 2014, another big one reappeared. And here, to tell you the importance of the anatomy, this is the right portal vein. The posterior's gone with this stuff, but this is the anterior one, so he's only got that. So it's all quite close there. And it was possible just to take that out. That was 2014. 2015, another lung. 2016, another lung met, had that done. 2017, another lung met. Not making much progress with that, so we had a lobectomy, lung resection. So that was last year. This year, had just one in the right, May, and I got a letter literally last week. There's a scan, no evidence of any disease at the moment. So that's actually 8 years of pursuing. So it sort of is worthwhile rather than just saying doomed, but not everyone fits into that. And he's obviously just got lucky tumour biology. And I think that's, oh no, so what am I going to summarise with? Surgery is the right thing to do. It's the only thing that totally sorts it out with curative intent. You expect them to have recurrence, so do anything you can to preserve as much liver as possible. Markers, CA, you know, number of lesions, none of those are absolute contraindications. Anything goes. So you can sort of pretty much do anything with good effect. Neoadjuvant chemotherapy is the standard of care now. Everyone has that, but there's no real strong evidence, but it just seems really sensible. And the MDT is the important thing. And I have lots of things that, you know, I haven't been around that long. Some things you just don't quite get what's going on, you haven't seen it. Take it with a group of people, there's always someone, oh, I've seen one of those, 52 or whatever. So, all right, and I'm going to stop there. So 2 slides to remember, the rest you can just be aware of. Any questions? All right.
Excellent, that was so beautifully clear and sensible.
Just thinking about concurrent resection of the colorectal primary. So, I haven't really talked about that, I suppose, but if you've got, say, you know, a cecal tumour and they've got hepatic mets, how do you stage? Because that's another thing I'm never quite clear on.
So I'm very aware I didn't put that in here because it's only half an hour.
Yeah.
But to me, the sensible answer to that is yes, do them together. You know, right hemiclectomy is not going to have a problem, so you can do that with a relatively major liver resection, and you can do major colons with minor livers. All right, so you just the biggest disaster if you do a big hepatectomy, you've got a big raw surface, then you get a leak, and that's really difficult. One other thing I'd like to say, as colorectal surgeons all here, if you know someone's got liver mets and you want to defunction them, please don't put a transverse colostomy up in the right upper quadrant, because you're talking about, I remember doing a right hepatectomy and they had that there, So I had to compromise, and there was faeces all over the place. So always an ileostomy, please. Does that make sense? So small bowel, big liver, big bowel, little liver.
And if you had to do the liver would probably take primacy, would it, to get it out
Well,
first?
no,
if you couldn't
no,
say it was a big...
only that's different. That's an exception. That's because those are the patients that are galloping through their chemotherapy. They haven't got another option. Right. Normally, no, I see your question now. Sorry. Bowel first. That's the classical way of doing it, and then sort the rest out later. Yeah, because that's where the Mets are coming from.
Yes.
Do you see what I mean? Yeah. So the longer you leave it there, the more likely you are to have more metastasis.
Would there be an exception though, if you've got a good response from a tumour that is close to an important structure like the IVC, and would you say, well, actually we've got a narrow window to get this met out, and we'd like to do the liver first, or is that wrong?
Yeah, that's all part of the conversation. Yeah, all this stuff is quite bespoke. You think about it, you just can't give generalised things. But I see what you mean. You're just making life complicated there. All right, I see what you mean. But what if I've got a cheese sandwich and some pickle? Yeah. Other questions?
So I understand the concept of parenchymal sparing surgery for when the Mets come back. Is there any evidence that doing a bigger resection in the first stage stops the future Mets?
Because one of the things I remember writing about these things, and one of the big, resection margin status, it used to be 3 centimetres, 2 centimetres, 1 centimetre, now it's about 1 millimetre. All right. No, that's not a good argument, because if I take the whole right lobe, you're not going to get a Mets, but it's still, no, they get problems and they die from things like this, so that's not a good thing to do. Yeah.
Any other questions?
Is there a role in metastatic disease for liquid biopsies, like take blood and spin it around, see if there's any cells in it?
Yes, I think there's some stuff published about that. But where are you wanting that answer to go?
Because my question was whether somebody has got metastatic disease in the liver or lung, and then whether you use that as a marker to check for whether they're going to get a recurrence or not.
Yeah, I'm sure people have written about that. There's some stuff published, but you've got to remember, if you've got 1,000 cancer cells all floating around your blood body, which is the proof that happens, it's only about 1 or 2. The percentage that actually stay in the liver is minuscule. Do you see what I mean? So that wouldn't be a...
But, they do like liver, don't they?
Yeah, but lots of them can land there, but they've got to grow and things, but yeah.
Okay.
I don't think that would alter management too much. It's just
sorry.
sort of interesting thing.
Very interesting talk. Is there an ideal time between the bowel surgery and a liver resection, or just get them to get better from the bowel surgery?
Well, usually what will happen, if they've got Mets, they'll have the bowel surgery, then they'll have the chemotherapy, then they'll have... Yeah, so you'll find
as soon as they finish the...
Yeah, it's when the oncologist starts. So it's actually the oncologists that are the coordinators and sort things out.
You like to time to recover from their oxalate?
Yeah. After they stop the chemo, it's a month, 4 to 6 weeks. Yeah.
I was wondering, you're saying that RFA is equivalent to...
Yeah, well, it probably is, but that so
resection for small tumours.
Yeah, well, think about it. In HCCs, there is now randomised controlled trials, big ones out in China, that show resecting and RFAing are just as good. What needs to be done is a randomised controlled trial for colorectal Mets, but no one will do that because, as I said here, surgery remains the optimal treatment. Yeah. So but I think it is. I mean, the logic behind RFAing, when you resect, you're hoping to resect everything, but if you can't, then you RFA it, because then it's better than not doing anything. Does that make sense?
Yeah.
They still do lots better.
But I guess you need to have with a small lesion, you're getting a good thermal effect.
Yeah.
With a big, I mean, it does make sense that it might not work so well for bigger lesions. You can't.
It's the size. It's the size. Yeah.
Any other questions?
I'd go for it.
So what is the size of lesion?
Well, 2 centimetres is optimal. My thumb is exactly 2 centimetres from there to there. All right, exactly. It hasn't changed. We used to have an adventurous one you can do bigger ones, but if you think about it, if you put one of those put it right in the middle, it burns a centimetre all the way around. Right, so you want something less than that. If it's bigger than that, you have to put it in, burn, put it in again, burn. Often you leave, it just needs 1 or 2 cells, so it's not ideal.
How's the number of resections you're doing? Is it going up dramatically?
It's not dramatically, no. I think there has been an increase, because if you look at old papers, lots of people in peripheral hospitals don't realise you can do something. And when people started doing something, lots of those patients died or didn't do very well. So there's been real reluctance. So I think there was an increase.
Do you think it will go up further?
Yeah, I think so. Saw people talking to each other and realising what can be done, because that's why I think it's very interesting going to see other surgeons work, because they do something, oh, that's a good idea, I haven't thought of that, because surgeons often work by themselves. They learn, then they get set in their ways, and they're not aware of the better ways of doing things. So the more communication there is, the better. Yeah.
Let's go one last question. What do you do with the complete radiological responders?
Yeah, well, again, it's all bespoke. I wait, and then
Yeah.
it comes back, and then I resect.
Yeah.
And it's always a bit annoying.
Yeah. Do you use
because then it's just. Oh.
do you use intraoperative ultrasound scan to
Absolutely.
help you identify tumours, but also to identify anatomy, or is that just
Yeah, no. Everyone that has a liver resection has an ultrasound scan.
Yeah.
Right.
intraoperatively looking
Yeah.
for anatomy,
Looking for anatomy and looking for things you haven't seen elsewhere. Yeah, or should have one anyway. But,
Any other questions?
yeah.
Okay. Well, look, I thank you all very much for coming. It's been very enjoyable for us. All the faculty have said how engaging and engaged you've been, and it makes a big difference to us that you've been so keen to ask questions and stay. It's been a long couple of days, really, but I hope the programme's been varied and interesting. It's been a pleasure to have you. There's feedback. We always need some feedback. Just be generous to me with my video. And then I think you get a certificate. The Europeans who are organising this conference seem to think that you're really going to want a certificate. I wasn't quite so sure. But please do give the feedback. And yes, I'm going to send an email out to all of you with a few papers from Mr. Dusmet from yesterday. We'll get the presentations together. Obviously, we'll have to take the video out, but we'll send the slides through once I've got permission from all the speakers. Apart from Mr. Spalding, he's got some pictures on this. He won't let he won't release them. And yeah, hopefully, if we run it again, you'll come back. Thank you very much.